Good morning, good afternoon, and good evening, everyone, from wherever you're joining us, and welcome to the 6th webinar in the Women's Health 2024 series. Today's webinar is titled Pathophysiology of Endometriosis, Current Concepts and Clinical Translations, featuring Dr. Rick Burney, the Director of the Division of Reproductive Endocrinology and Infertility at the University of Alabama at Birmingham. Today, he will review the evidence supporting the current understanding of endometriosis pathogenesis and pathophysiology, recent advances that leverage this understanding, and the clinical translation challenges that still remain. Before we get started, I would just like to acknowledge our partners for this series, the American Physiological Society, the Society for Women's Health Research, and Scientist.com. We'd also like to say a thank you and give a shout out to all of our series sponsors. None of this would be possible without them. I'm Sarah McFarland from the events team here at Scientist.com, and I'm happy to be your host for today's event. Before I welcome our speaker to the floor, I just wanted to cover a few housekeeping notes to help you get the most out of your experience today. First, take a look at that interactivity panel at the right of your screen with 4 tabs: Chat, Q&A, Polls, and Handouts. This is where you'll participate in the Q&A as well as access all resources. We want this to be an interactive experience for you, so please send your questions, thoughts, and comments using that Q&A tab, and we'll try to address as many of your questions as we can at the end of the webinar today. You can also explore some links and documents in the Handouts tab to learn more. And lastly, if you're having any technical issues, please try refreshing your browser and ensure that you're using Google Chrome to access this event, as it is the most stable browser. If you're still having trouble after you refresh, use that private chat function to communicate with me by sending a chat to Sarah, and I can help you to troubleshoot. Okay, and now I'm very pleased to welcome our speaker, Dr. Rick Burney, to the floor. Thanks for being here, and take it away whenever you're ready.
Super. Well, thanks for that introduction, Sarah. I really am delighted to be here this morning. I thank the societies for all of the preparation and for hosting this very valuable series in women's health. During this morning's presentation, I hope to acquaint the audience with some of the fundamentals associated with a condition called endometriosis. We're going to review some concepts and clinical translations associated with this challenging gynecologic condition. I'd like to say at the outset that the views are my own and don't reflect the University of Alabama at Birmingham or any of the sponsors. I will be sharing photos. These are from cases that I have conducted and received consent to share from the patients that were involved in those procedures. These are our learning objectives this morning. I'm very interested to acquaint you with the theories regarding the pathogenesis of endometriosis, as well as discussing the molecular underpinnings of this disease process. We're going to talk about current diagnostic challenges and the limitations associated with the paradigms we use to diagnose this condition presently. We're also going to talk about different approaches to the treatment of this particular condition, specifically a two-pronged approach that I have found clinically to be very valuable in the treatment of women affected with this condition. So endometriosis, it's a very prevalent condition. It's estimated to affect 190 million women worldwide. The stated prevalence of the condition in the reproductive age population is 11%. 40% of women who present with particularly unexplained infertility are found to be affected with endometriosis at laparoscopy. This is a disease process that represents a significant healthcare burden both to individuals as well as the healthcare system in the aggregate, costing over $80 billion annually. Unfortunately, this particular condition has been very resistant to the discovery of a laboratory diagnostic, resulting in an average delay in diagnosis from the onset of symptoms of 7 to 10 years. This represents a major clinical gap in the clinical approach to endometriosis. It's treated oftentimes with hormonal management strategies. And because of this, only about 1 in 3 women feel that the treatment is effective. Precision medicine approaches to endometriosis are developing, but still have not reached the point at which the first choice is the right choice with respect to endometriosis management for a given patient. This is a condition that doesn't enjoy a great deal of awareness. It's possible that this is the case because it is a gynecologic condition that is associated with menstruation. And so it may not get as much education and awareness as perhaps some other conditions may enjoy. Only about 20% of the general public have heard of this particular condition, although that's changing. At least in recent years, endometriosis seems to be more prevalently searched on internet browsers. And in 2018, it was the 3rd most searched health question, returning over 31 million results. So that's encouraging. I'm going to get into pathogenesis and pathophysiology of this particular condition. It has its origins in 1927 as far as description. At that point, Dr. Sampson described in brilliant detail with amazing artistry renditions of endometriotic findings that I've depicted on this slide, the process that he purported for endometriosis. And his theory was the theory of retrograde menstruation. There are other theories that have been articulated for the pathogenesis of this enigmatic condition. One of them is induction. In this particular theory, estrogen is thought to induce metaplastic changes in the cells that the epithelium that lines the pelvic peritoneum. There's also a theory that endometriosis has an origin from stem cells, especially either uterine or bone marrow derived stem cells that have a particular predisposition to implantation in the pelvic peritoneum. And then finally, because of the sometimes distant location of endometriotic lesions, the theory of transplantation of this endometrium to these various locations has been advocated. And as I mentioned, one of the more compelling theories associated with the displacement of intrauterine endometrium to ectopic locations, particularly in the pelvis, is that of retrograde menstruation. Other transplantation possibilities include lymphatic, as well as the vascular dissemination of endometrial fragments during menses to more distant locations. Endometriotic lesions are described as a combination of endometrial glands and stroma in locations outside the uterus. And lesions have been located in the brain, the pulmonary system, in abdominal scars, but more commonly are located in more proximate locations in the pelvis, to include the pelvic peritoneum, the ovaries, the bowel, and supporting structures within the pelvis. The evidence for retrograde menstruation is particularly compelling. This disorder is usually found almost exclusively in women of reproductive age who are experiencing menstrual cycles. It is known that prolonged regular menstruation does lead to an increased risk of endometriosis being detected at laparoscopy. Anything that does interfere with the antegrade transit of menstrual product can lead to retrograde transplantation of that product into the pelvic cavity. So obstructive Mullerian anomalies such as a uterine septum have been associated with an increased risk of endometriosis, and we'll talk about that. Finally, the patterns of disease that and lesion location in the pelvis are consistent with retrograde menstruation, insofar as the lesions are more commonly found in dependent areas of the pelvis, particularly around the opening of the tubes. So retrograde menstruation holds that during menses, the menstrual product transits the fallopian tubes and deposits within the pelvis. And within that pelvic microenvironment, these lesions can attach, implant, and grow in extrauterine locations. This slide depicts the more prevalent locations of endometriotic lesions that are discovered at the time of laparoscopy. And you can see in this particular photo that lesions tend to be more commonly found around areas where the end of the fallopian tube may be resident, such as the ovary, the fallopian tube itself, the broad ligament, which is a ligament that transits the uterus to the ovary, the uterosacral ligaments, which are supporting ligaments for the uterus that are located near the distal end of the fallopian tube. Of note in the description of lesion location, the left seems to have more of a propensity for lesions to implant than the right. The thinking behind this is that the left hemicavity of the pelvis has the sigmoid reflection, which acts as almost a backstop to the abdominal pelvic gutters and immune clearance of these, the retrogradely menstruated tissue. So because of that, the left side tends to be more static and has more of a propensity for the retrogradely shed lesions to implant, underpinning that spatial disparity between left and right at the time of laparoscopy. The appendix can also be involved in about 15 to 20% of cases. In a landmark study in the history of endometriosis literature, Halmy et al. In 1984 found that 90% of women had endometrial cells in the pelvic cavity at the time of menses. In this particular study, the team intentionally performed laparoscopy at the time of menses in order to arrive at an answer as to whether or not retrograde menstruation was unique or prevalent. And their studies demonstrated that retrograde menstruation is actually more likely physiologic than pathologic, given the 90% prevalence of retrograde product in the pelvic cavity. Studies of peritoneal dialysate confirm that retrograde menstruation is a prevalent phenomenon, with 76% of the patients in that series showing endometrial product in the dialysate around the time of menses. However, despite the prevalence of retrograde menstruation identified in these studies, the prevalence of the disease condition is only 6 to 11%. So this disparity between the presence of product and the implantation and lasting presence of product is the area of active research in endometriosis, pathogenesis, and pathophysiology. And it's the implantation and growth of that retrogradely transited endometrium that is the selective, unique phenomenon in endometriosis. So what are the factors involved in the implantation of endometrial product into the peritoneal cavity? And I lift up a New England Journal of Medicine review article from Dr. Linda Giudice, and this images a encapsulation of endometriosis pathophysiology found in that review article. Some of the factors that have been purported include a peritoneal factor. Perhaps there's something unique about the mesothelium of the pelvic peritoneum that makes it particularly sensitive or receptive to endometrial fragments implanting. And this line of investigation has identified matrix metalloproteinases, specifically 3 and 10, as potentially being etiologic in lesion development. Alternatively, or in combination, a hormonal factor may be important to the implantation of these peritoneal fragments. And in particular, this disease condition is known to be hormonally dependent, specifically estrogen dependent. There are multiple lines of evidence that show that in the absence of estrogen, the disease process regresses. And in the presence of estrogen, particularly supraphysiologic estrogen levels, this disease progresses. Estrogen receptor alpha in particular may be etiologic in the development of these lesions. Typically, retrogradely menstruated product is cleared from the abdominal pelvic cavity by immune clearance mechanisms. It is thought that there is potential for this disease to begin due to an impairment in the immune clearance mechanism in affected patients. And studies of peritoneal fluid from women with and without disease have identified distinct immune signatures and cell types that would tend to underpin that impairment of immune clearance may be part of the implantation process. Finally, it's possible that a heritable or acquired factor within the endometrium itself places women with endometriosis at particular risk for the retrogradely menstruated product to implant within the pelvis. Toward that end, we've accumulated quite a bit of evidence that the endometrium from women with endometriosis does have some alterations. This study was a study that looked at gene expression signatures in women with and without endometriosis, looking at the endometrium from those patients. And the study included 21 subjects in each arm, and a whole genome microarray analysis was performed that demonstrated striking differences in terms of gene expression signatures in the endometrium from women with and without endometriosis, particularly in the early secretory phase, which is that 3 to 4 day phase of transition from the estrogen dominant proliferative phase to the progesterone dominant secretory phase. And this dysregulation of the early secretory phase in the endometrium was one of the first lines of evidence of a phenomenon, another molecular hallmark of endometriosis, referred to as progesterone resistance. And the gene expression profile from women with endometriosis demonstrated a downregulation of progesterone regulated genes in their endometrium, consistent with a delayed or absent responsiveness to progesterone. Also supporting that there may be a heritable difference in either the mesothelium of the peritoneum or the endometrium are studies that have elicited a genetic basis to endometriosis. This was originally described by Burney, who followed families affected with endometriosis and noted a familial disposition to disease. Subsequent monozygotic twin studies revealed that genetic factors contribute about half of the risk to disease disposition. Endometriosis has been fortunate as a disease condition, a gynecologic disease condition, to have very large genome-wide association studies done to explore a genetic component to the disease. The most recent genome-wide association study revealed that 26% of the risk for endometriosis was accounted for by the genetic variants that were seen in the study. So collectively, to wrap up pathogenesis and pathophysiology of endometriosis, it starts with retrograde menstruation. We talked about the prevalence of the phenomenon of retrograde menstruation, and that being a prelude or a prerequisite, I should say, to the development of the disease condition. These viable endometrial cells in menstruation then find a position in the pelvis to attach and implant. When they implant within the pelvis, they start off as a red vesicular lesion. We'll talk about lesional subtypes in a subsequent slide. The endometrial implants remember their roots as endometrial in origin. And in subsequent menstrual cycles, we and others have noted that there is menstruation from these red vesicular lesions. And this bleeding from the lesions that occurs is possibly contributory to the pain associated with the condition at the time of menses, but also is thought to be a precursor to the development of subsequent fibrosis, the attachment of proximate structures to one another, which is seen in the more advanced stages of this disease, can be typified by very extensive adhesions between the bowel and gynecologic structures, between the gynecologic structures themselves. This can result in significant pelvic distortion that can affect both quality of life as well as fertility. I mentioned the molecular hallmarks of the condition, and we've covered some of them already, but to outline them as they are known currently, they include estrogen dependence. Endometriosis is a chronic inflammatory condition because the body does recognize these extrauterine endometrial implants as being incorrectly positioned and mounts inflammatory responses to the lesions on a month-to-month basis. A third molecular hallmark is neuroangiogenesis, which is the ability of the lesions in ectopic locations to secrete compounds that recruit blood supply, as well as neuronal influx. And chief among these compounds is vascular endothelial growth factor and nerve growth factor, both of which have been identified within endometrial lesions. Finally, the phenomenon of progesterone resistance has been associated with endometriosis. So how is this disease condition diagnosed? Unfortunately, there is no molecular biomarker that has been identified for a convenient laboratory-based assay to identify disease. And in the absence of that biomarker, the paradigm for diagnosis relies on clinical acumen. The presentation on the part of patients is typically one of pain, and the different varieties of pain that patients will present with include pain with cycles, pain with intercourse, pain with bowel movements. There can be some unusual pain symptoms if the endometriotic lesions are located in more distant locations, and unexplained infertility. One of the more recent discoveries with regards to signs and symptoms associated with endometriosis is the phenomenon of premenstrual spotting. And premenstrual spotting is, as it sounds, spotting vaginally prior to the onset of full flow of menses. And this has been found to be a fairly accurate sign for endometriosis, particularly in women presenting with infertility. One of the constructs that I like to use when I'm treating a patient with endometriosis-associated pain is the International Pelvic Pain Society's intake questionnaire. And this questionnaire is very extensive and allows me to gain insights with regards to the impact of the condition on quality of life, different approaches that have been tried prior to the presentation in my office, as well as some of the patient's goals associated with treatment. I find that there are also some parts of the International Pelvic Pain Society questionnaire that are easier to assay through the questionnaire than they may be in an interview forum. So I really value this when working with patients with endometriosis. Also, the Pelvic Pain Society has information for patients that is very evidence-based and does provide the education that I'd really like for my patients with pelvic pain and endometriosis to be aware of. Beyond the history associated with an endometriosis patient, diagnosis can be had based on imaging studies, specifically ultrasound and magnetic resonance imaging can be valuable towards identifying particularly ovarian disease. Ovarian disease is also known as an endometrioma, which is a hazy appearing cyst within the ovary itself. This particular version of endometriosis is a consequence of an endometrial implant that has been able to infiltrate the ovary and start to menstruate repetitively into a cyst capsule, resulting in a quite fibrotic cyst within the ovary itself that doesn't oftentimes regress spontaneously. And these can be identified fairly readily on ultrasound or MRI, which are very sensitive and specific for picking these up. Another finding that can be associated with endometriosis, particularly peritoneal endometriosis, is the finding of a retroverted, commonly referred to as a tilted uterus. I've got an image of that in the top image there, which shows what a retroverted endometriosis might look like on ultrasound. Finally, there's a version of endometriosis referred to as deep infiltrating endometriosis, or DIE. This version of endometriosis is found underneath the pelvic peritoneum and can be particularly painful. It's a version of endometriosis that's best identified with magnetic resonance imaging. I mentioned patient handouts. This one's specific to endometriosis itself. And then finally, when it comes to the diagnosis and treatment of endometriosis, the gold standard for diagnosis is the finding of endometrial glands and stroma in a biopsied lesion at the time of laparoscopy. Laparoscopy is also used to diagnose the condition without histology, but histology really is the best way to ensure that you have a solid diagnosis for a patient. Because surgery is required for the diagnosis, oftentimes this underpins the delay in diagnosis that I mentioned previously of 7 to 10 years. Unfortunately, because of this delay in diagnosis, there may be repercussions for patients. There is evidence that this particular condition is a progressive disorder. So delay may be associated with a worsening of the condition and more implications with regards to quality of life as well as fertility. So I mentioned earlier about the lesional phenotypes, and I showed you the red vesicular subtype of a peritoneal lesion. Recognize that this lesion that's seen on the screen here is a fairly new lesion that has started to release agents to engage neoangiogenesis. These particular lesions tend to be high in hormonal activity, specifically vascular endothelial growth factor, and are associated with dysmenorrhea, perhaps because of the repetitive menstruation that's associated with these in subsequent menstrual cycles. Over time, the lesion may change in its phenotype to more of a powder burn type lesion, likely as a consequence of repetitive inflammatory exposures of the lesion itself. These lesions are typified by a different pelvic pain profile, or more associated with non-menstrual pelvic pain, less of a hormonal profile, and are associated with pain with intercourse. Finally, the body does have the ability to self-heal from these endometriotic implants, and that's more typically visualized as a white fibrotic lesion, which oftentimes can just be seen as scarring of the pelvic peritoneum. That's still associated with symptoms, particularly dyspareunia, but there's not much in the way of hormonal activity associated with that particular lesional phenotype. This is some of the evidence that these lesions actually transition through these different series of phenotypes. This was a study of the lesional phenotype that showed that in younger patients, there was a higher prevalence of these red vesicular lesions, these newer type of lesions, whereas in older patients, the lesions tended to be more powder burn or white fibrotic type lesions. And this provides some orthogonal evidence that these lesions progress over a series of stages as a response to repetitive inflammatory events. With regards to neoangiogenesis, this can be very pronounced in some patients, with neoangiogenesis kind of giving a very angry appearance to the pelvic peritoneum. This is a function of that release of vascular endothelial growth factor and can be leveraged to advantage during the treatment of endometriosis using the Firefly option of the robotic platform for locating lesions. In this particular study, they used that type of imaging approach to pinpoint lesions on the basis of increased blood flow to those areas of the peritoneum. So oftentimes we're challenged with whether or not it's best to excise a lesion or to fulgurate the lesion at the time of laparoscopy. This represents one of the more common treatment approaches to this disease condition. I tend to favor, and others as well, excision of lesions, not only for treatment purposes, but also for diagnostic purposes. And I've been I've been an advocate of this, mostly on the basis of a study that was done by Marchino that showed that the visual impression of endometriosis may not always be consistent with the histopathologic impression of a given lesion, and that surgeons may only be accurate 50% of the time. So with as much that goes into endometriosis diagnosis and treatment for patients, I feel like precision in terms of the diagnosis is really important for a given patient, and that precision can be better had through a biopsy of the lesion to get the histopathologic confirmation. This histopathology image shows the findings that are more typical from an excised lesion, insofar as you see endometrial glands, endometrial stroma, also some flash points of hemorrhage. Sometimes hemosiderin will be found in the excised lesions. There is a condition that's associated with the presence of just glands, but no stroma. It's a separate condition that's known as endosalpingosis. So the gold standard for the diagnosis of endometriosis is the presence of both those glands and the stroma. At surgery, this particular condition is typically staged, much like cancer is. The staging is based on the distribution of the implants, so as to give an idea of volume, as well as the location of disease and the presence of scarring. The revised American Fertility Society staging system was the system that was most commonly used for years. And it does provide a framework for discussing endometriosis between providers and researchers. Unfortunately, this system does not correlate well with pelvic pain. So the finding among many was that patients with advanced stage disease may have minimal pain and vice versa. So it does show a little bit more value with regards to categorizing the burden of disease as it relates to the selection of fertility treatment. But for pain, it hasn't been particularly useful. One of the reasons for this may be because the system doesn't account for the different phenotypes that I mentioned earlier and the different types of pain that's associated with that. These days, stage 1 and 2 disease is generally combined when discussing volume of disease, and stage 3 and 4 are combined as well when discussing endometriosis. Pain is a central feature of endometriosis and oftentimes the presenting complaint. In recent years, the discoveries associated with the type of pain that endometriosis results in have been very revealing. As I mentioned earlier, neurotropism is a feature of a molecular hallmark associated with endometriosis, resulting in neural sprouting, and really initiates that somatic pain network that is prevalent in this disease condition. Deep infiltrating endometriosis has been associated with nerve fiber density, correlating with pain severity. And this phenomenon of central sensitization associated with the estradiol component of the condition is very, very central to the understanding of the pain associated with this condition. In some patients, despite treatment of the lesions, the repetitive ebb and flow of estrogen can, in and of itself, result in pain complaints on the part of a treated patient. Infertility is also a feature of endometriosis that receives a lot of research attention. The study by Dr. Barnhart of a meta-analysis level really established endometriosis as a cause of infertility. The reasons for endometriosis resulting in infertility have been explored at various stages of the human reproductive process and seem to affect nearly all. The common denominator to these impacts is the chronic inflammatory nature of endometriosis, and inflammation and reproduction are at odds oftentimes from a molecular standpoint, and inflammation itself can be a very deleterious to the fertility process. So this is likely the molecular link between endometriosis and infertility. We're going to segue next to a treatment of endometriosis. And I think that it's important to understand that when it comes to the management of this condition, it's really predicated on whether or not the patient is interested in fertility. And the reason for that is because many of the medical approaches to endometriosis are not facilitated for fertility because they are hormonal in nature. So once you've established whether or not family building is a priority for the patient, you can engage in different treatment approaches. The one treatment approach that is common to both the treatment of endometriosis-associated pain and infertility is surgery. I refer to this prong of endometriosis management as the treatment of existing disease. The second prong in endometriosis management is the prevention of recurrence, because as we talked about earlier, as long as a patient is menstruating, she may be retrogradely menstruating, and if she has a predisposition to endometriosis, may experience a recurrence without management. So along the prong of treatment of existing disease, laparoscopy and more recently robotic assisted laparoscopy has a very central place. One of the current conundrums associated with the management of endometriosis is what to do about endometriomas. Recall that those are the lesions that exist within the ovary itself, particularly in the setting of infertility. Excising cysts that reside in the ovary can be challenging insofar as it could result in collateral damage to desired ovarian reserve, which is the pool of eggs in the ovary. So these days, oftentimes we use a threshold size for endometriomas to determine whether or not surgery for that particular endometriotic lesion within the ovary is of value. From a pain standpoint, the Cochrane review of endometrioma excision is very compelling that it's beneficial for the reduction of pelvic pain associated with endometriosis. I mentioned that even slight outflow tract obstruction can predispose to increased retrograde menstruation and prevalence of disease. This image represents a uterine septum, or a wall that's extending towards the cervix from the fundal aspect of the uterus. And this can result in endometrium in either hemicavity being obstructed from antegrade flow and having more of a propensity to enter the pelvic cavity from the fallopian tubes. And studies have demonstrated that women with endometriosis do have a higher rate of, women with uterine septum have a higher prevalence of endometriosis than those that don't. Also associated with treatment of existing disease is the phenomenon of recurrence. And it has been shown in multiple studies that if that second prong of prevention of recurrence is not engaged, then 75% of patients will have symptoms recur, new lesion development, within 2 years of the index surgery. So this underpins the second prong of trying to prevent the recurrence of these lesions, usually through a hormonal treatment strategy. And some of those treatment strategies can be engaged at the time of the laparoscopy. For instance, the placement of a levonorgestrel containing intrauterine system, such as this is an IUD that through progesterone release at the level of the endometrium can render the lining more atrophic and less prone to release retrograde product into the pelvis. Another strategy is to use a gonadotropin releasing hormone agonist or antagonist in order to menstrually suppress and prevent the recurrence of the condition. In fact, there are a number of strategies that can be engaged to prevent recurrence of endometriosis. They have as their common denominator the rendering of menstruation either reduced or absent. Because without that menstruation, there should be less of a propensity for the transplantation of those endometrial fragments, either through retrograde menstruation, lymphatics, or vascular. So I've outlined a few of them already, as far as the levonorgestrel intrauterine system, as well as the agonists and antagonists. But there are a number of different medication-based approaches that can be used. Unfortunately, we don't really have a great triaging system to know what might be the right medical approach or hormonal approach for a patient, for a given patient relative to another patient. And there's increasing attention being given to that towards personalizing endometriosis treatment. This can be done in a variety of ways, and newer studies are actually looking at lesions to profile those lesions for purposes of both response to treatment, as well as to provide awareness as to whether or not there's any cancer risk associated with progression, particularly in the instance of endometriomas or ovarian endometriosis. Several studies I'll lift up that have been reported recently include a tissue microarray-based study that showed that different lesional profiles are associated with hormone responsiveness. So the vision is that by biopsying the lesion and testing for a few molecular analytes, we may actually be able to get a read as to whether or not the prevention of recurrence is going to be more receptive for a given patient. Another study looked at genome-wide associations for gabapentin efficacy in endometriosis. Gabapentin is a potential pain treatment approach for patients with endometriosis. And these investigators found that a locus in the neuregulin 3 gene was associated with gabapentin efficacy. So this is an example of pharmacogenomics potentially being leveraged to triage the approach to a patient found to have endometriosis. Finally, endometriosis associated infertility has been studied with regards to the impact of surgery in improving the odds of fertility. This is somewhat dated trial, but one of the better studies that have been done regarding the value of surgery for endometriosis is published in the New England Journal, and it involved over 300 women with endometriosis undergoing laparoscopy. For those that had stage 1-2 disease, so the more earlier stages of disease, laparoscopy-based treatment of those lesions was associated with an improved pregnancy rate. Unfortunately, a subsequent study did not show similar results, but the meta-analysis still indicated value to laparoscopic treatment of lesions towards improving fertility. Good news is that awareness, just like the Google search slide that I showed at the beginning of my talk, awareness and funding is on the rise, not only from the general public, but also amongst funding agents. Probably one of the best action plans that have been described for endometriosis is Australia's, really providing a blueprint for national campaigns to improve awareness and research in endometriosis. But there are others. In the United States, a endometriosis caucus was founded in 2019, and NIH funding has increased for endometriosis from $13 million in 2020 to $27 million in 2022. States also are getting engaged in improving awareness and action in endometriosis, with Connecticut leading the way with a bill that was passed called an Act Concerning Endometriosis. This established a state-funded data and biorepository program in 2023. This most recent legislative session included a reintroduction of the Endometriosis Care Act. This is an act that would provide funding support for endometriosis research, and is really predicated on the concepts of coverage, awareness, research, and education in this disease condition. So what remains regarding challenges and gaps? The one that really hopefully was pervasive throughout my talk is the gap that is remains regarding a non-invasive biomarker for this disease condition. There are increasing studies that are global proteomic in basis, and even endometrial sampling or menstrual cap collected endometrium-based approaches to biomarker development in endometriosis, but a lot is needed there. That's probably the principal gap that remains in this particular disease condition. And once that gap is solved, I think that it will really accelerate our abilities to gain insights for this condition. The delineation of the genetic basis is resolving, but there are still gaps remaining with regards to particularly the mechanisms of implantation that separate retrograde menstruation from endometriosis as a disease condition. And then finally, the development of agents that address pain and perhaps fertility that are non-hormonal in nature would be a real advantage in the management of this particular disease condition. I mentioned the molecular hallmarks associated with the condition, and they provide avenues of approach for pharmaceutical agents to potentially help prevent and treat this condition along the lines of inflammation, as well as anti-angiogenic approaches. And there There's some reports recently of some very promising candidates along these lines that hopefully will provide some non-hormonal approaches to endometriosis pain. Okay, this is my last slide, and to take it home, I want to highlight the molecular hallmarks of inflammation and estrogen dependence. I would add to this that one of the more recent lines of investigation in endometriosis is that molecular process of fibrosis as being central to particularly in the ovarian form of this disease. The two-pronged approach, treatment of existing disease as well as prevention of recurrence, these really need to go hand in hand towards effectively treating and preventing recurrence of this condition. Third, that endometriosis is not only somatic locally, but also a condition of central sensitization. And this too represents an avenue of approach towards modulating the pain associated with the condition. And then finally, here at UAB and certainly other places that manage patients with endometriosis, we really consider this condition to be a multifactorial one that also requires multidisciplinary intervention. We didn't talk about all of the disciplines that may be represented in that multidisciplinary approach, but certainly that is the preferred way of approaching endometriosis from the standpoint of treating the patient holistically. And with that, I am going to open up the floor for any questions that you have. Thanks for having me this morning.
Thank you so much, Rick. Wonderful presentation. I'm going to give you just a few moments to catch your breath and get a sip of water before we jump into our Q&A.
Sure. Thank you.
Okay. I want to take this moment just to remind the audience to send any questions you have for Rick in the Q&A tab on the right of your screen. And if you do have to leave early, I am going to launch a survey pop-up here for you. So if you do have to pop out a bit early, we would love to get your feedback on our survey. Just let us know about your experience today. Okay, so we do have quite a few questions here, so that's fantastic. Rick, I'm going to bring you back in. Hi, welcome back.
Hey.
I'm going to get started if you're ready.
Ready.
Okay, the first question that I have here is, last I saw, 2 years was the maximum time recommended for continuous dual non-cyclical hormone treatment that prevents controlled bleeding. Are there any new recommendations regarding longer continuous dual hormonal treatment and its risks?
Yeah, that's a great question. And really, I think that's focused on some of the GnRH agonist and GnRH antagonist based approaches that I had mentioned. And I think there's increasing studies about extending the duration of that treatment. Most of those are involving add-back. And add-back, I did not mention in the talk, but add-back is where a progestin with estrogen qualities or estrogen itself is actually provided to the patient to mitigate some of the vasomotor or hypoestrogenic side effects associated with extending that suppression. I haven't seen any guidelines that extend that window. I will say that if a given patient is showing great treatment effect and is maintained on add-back, I will actually consider extending that window, particularly if I have readout on bone mineral density being not compromised by the duration of the suppression. So I haven't seen it official, but it can be done, I think, in a shared decision-making model with the patient.
Okay, thank you. We have a question here. I'm going to save it for the Q&A report because there's a link to a study, but you guys will get an email with that Q&A report when it's ready, so you'll be able to see that answer. The next question here is, what is the reason for such a long delay in diagnosis?
Yeah, that's a great question. I think that there are a few contributors to that. One is that this condition typically presents in adolescents and young adults, and sometimes it's just a discussion that's not had, perhaps, or a discussion that is maybe a lack of awareness or education associated with the general public and providers to recognize some of those early signs and symptoms that differentiate just pain or cramping with menstrual cycle from endometriosis. And in the absence of a biomarker, a convenient laboratory assay that can delineate the presence of endometriosis from other contributors to cramping, it's very difficult to tease out. I also think that there's a reticence generally to doing surgery in adolescents and young adult patients, and understandably, because of the risks associated with surgery. So coming up with a non-surgical diagnostic for endometriosis is a major, major gap.
Okay, thanks. The next question here is asking about, in the absence of biomarker tests, as you just mentioned, are ultrasounds a good way to make a diagnosis? And if so, why aren't they done more regularly?
Yeah, great question. So ultrasound is a very good way of diagnosing the ovarian form of the condition. Unfortunately, the ovarian form of the condition is not always present. And you can have the peritoneal version of the disease either in isolation or in combination with the ovarian version. So if we just relied on ultrasound or MRI to make the diagnosis, may miss quite a few patients that have endometriosis of the peritoneal variety, because we just don't have a very good imaging-based diagnostic for that version of the disease. And that probably is the most prevalent version, is the peritoneal form of endometriosis. But for those patients that have ovarian disease, in other words, these endometriomas that are present within the body of the ovary, ultrasound is an excellent way to diagnose. I didn't mention it in my talk, but there's increasing oncologic awareness associated with endometriomas. Increasing studies are showing, there's one published in JAMA, I think last year actually, that really provided some strong epidemiologic evidence for an association between endometriomas, in particular ovarian cancer subtypes, namely clear cell and endometrioid type ovarian cancers. So for patients that have endometriomas or ovarian disease, I think it's important to really maintain some surveillance over that version of the disease. And when family building is complete and the ovarian reserve is not, and potentially not as much of an issue for the given patient, have those ovarian cysts removed from the ovaries to try and minimize risk.
Okay, thank you. This next question I think came in a little bit before you mentioned your treatment options in your slides, but I'll ask it anyways. You mentioned in the profiling of lesions part of your talk that it could inform cancer risk, which you just also touched on.
Mm-hmm.
Does endometriosis in both forms, peritoneal and ovarian, increase the risk of cancer?
Yeah, great question. As I mentioned, the ovarian form has been linked, and some of the more compelling data that underpins this linkage is the presence of somatic mutation, and it has been found that endometriomas are somatic mutation rich, and some of these somatic mutations may predispose to that oncologic progression. Peritoneum, not as much. There are associations between the presence of peritoneal disease and subsequent cancer risk, but an actual etiologic or molecular link between them has not been as well described as that exists between ovarian endometriosis and cancer.
Okay, thank you. Oh my gosh, we have so many questions. I'm going to keep going, even though we are only about a minute out, if that's okay with you.
Sure, yeah.
Okay. This next question here is related to the impact of menopausal women. So, what is the usual impact that can be expected on the level and type of symptoms and pain for women with severe endo post-menopause? How does using hormone replacement therapy post-menopause impact women with endometriosis?
Wowzer, that's a whole nother talk. That's a great question. Endometriosis being an estrogen-dependent disease is not as prevalent in the postmenopausal population, and hormone replacement obviously can change that dynamic. Um, it's interesting when it comes to hormone replacement, because this is endometrium that is outside the uterine cavity. Oftentimes, it is advocated from a hormone replacement perspective, to utilize both estrogen and progesterone to protect against the endometrial cancer predisposing impact of estrogen when a patient has endometriosis. I think there's still more studies that need to be done with regards to that in terms of risk mitigation. We don't commonly see, and it's probably a consequence of the threshold effect. In other words, there needs to be a certain physiologic amount of estrogen present for endometriosis to be progressive. But we don't see estrogen replacement as oftentimes exacerbating previous endometriosis, because overall the amount of bioavailable estrogen is lower. So it shouldn't deter the decision to engage estrogen if the patient is a candidate for that estrogen otherwise.
Okay, thank you. Next question here. Hopefully you will be able to answer it. There's been a few, and I'm going to summarize all of them into one. Is there an animal model for endometriosis? And if so, could it add anything new to the research being done in this field?
Yeah, another great question. There are animal models for endometriosis. Endometriosis being a retrograde menstruation-based disease, is only found spontaneously in nature in a select few species. And those species all have as their common denominator an opening or a gap between the end of the fallopian tube and the pelvis. Oftentimes in some of the animal species, there's a bursal sac that keeps this anything that's retrogradely menstruated, if the species menstruates at all, from getting that retrograded product disseminated into the abdominal pelvic cavity. So there are only a few models where you can investigate endometriosis in the spontaneous sense. And those include the non-human primate models. So the baboons species in particular has been demonstrated to spontaneously develop endometriosis without any kind of manipulations required to get the disease to start. Otherwise, in smaller animal models such as mice, manipulations are required. And Katie Burns at the University of Cincinnati and I did a review article on the various models in the mouse for recapitulating endometriosis just a few years ago. And I would reference you to that review article. It's fairly extensive. There are a number of ways to try and develop endometriosis in the mouse, but they do require manipulation in order to do it, because it's not a disease that the mouse species, the murine species, spontaneously develops.
Okay, thank you. I'm going to have you put that into your Q&A report for everyone,
Okay.
if that's okay with you.
Sure.
All right, we are almost 5 minutes past, so I'm going to make this the last question.
You got it.
Okay. Fibrotic lesions occur in other organs with other disorders. What have we learned from studies in the lung and the kidney, et cetera? And are there similar pathways that can be targeted for endometriosis treatment?
I'll answer the last part of the question first, because I'm not really sure about the former part of the question, in terms of leveraging some of the insights from other fibrotic conditions. I think that the pathways, from what I understand, are fairly common. And the fibrosis associated with endometriosis is twofold. First is what I depicted in the slide set with regards to fibrosis in the peritoneum. The second version of fibrosis that's really germane to endometriosis associated infertility is recent studies that have demonstrated histologically fibrosis within the ovary. And that chronic inflammatory condition is predisposing to the development of fibrosis within that ovary, which can impact the ovarian reserve or egg pool. And that can accelerate the decline in the ovarian reserve. And so we are very interested in the molecular hallmark of fibrosis as it relates to fertility.
Okay, fantastic. Rick, I just want to thank you so much for being here today, your presentation, your insights during the Q&A. It really was a pleasure to have you with us, and I hope you enjoyed yourself.
I thoroughly enjoyed it. Thank you so much to the societies for this series. Thank you, Sarah, for all that you do to make this go. It is amazing. I like to use the phrase that preparation is separation, and all the preparations that you make are amazing. So thanks for all that you do, and thanks for having me this morning.
I appreciate that. Thank you so much, Rick. Okay. And I also want to thank our live audience. Of course, you all have busy schedules, so being here live, we really appreciate your participation. I wanted to send a reminder that there will be another webinar next week, Wednesday, December 11th at 11 a.m. Eastern Time. You'll get an email reminding you about it, but make sure to block it off in your calendar so you don't miss it. A quick reminder that a recording of today's webinar will be available soon, and you'll also get an email letting you know about that and giving you access to that. Additionally, at the end of this webinar, a survey will appear. We do read all of your comments and appreciate your input, so please let us know what you would like to see from us in the future, and let us know about your experience today. And finally, if you still have questions for our speaker, you can submit them in the survey, and I'll make sure to pass them along to Rick. In closing, I hope that you enjoyed this Inside Scientific webinar produced in partnership with the American Physiological Society, and we'll see you next week.